Hello everyone, and welcome back to Healing Her Sacred Light. As you can see by the title in today's video, we are going to be discussing a topic within our Womb Science and Health series, and that is the physiology of hospital births. As some of you may know, I was in medical school and I withdrew during my third year. I went to medical school because I wanted to heal people. I truly believe I'm a healer. I wanted to save lives. I wanted to be useful in moments that mattered. When I started my third year rotations at the hospital, OBGYN was my very first one. I was excited, bright-eyed, hopeful, but as the weeks passed, that bright light in me started to dim day by day. Not because the work was hard, and it was tough being at the hospital 12 hours every day, some days longer, but it was because many of the practices I was witnessing didn't sit right with me. And at first I couldn't fully explain why. In medical school, we weren't really taught to think beyond the institution, the machine, the system. We could only think within that box. So I started researching on my own. And the more I learned about physiology, about hormones, the nervous system, and how birth actually works, the more I understood why my body had been reacting before my mind caught up. I wanted to become an obstetrician. I even did a maternal fetal medicine elective during my third year. But I began to realize that many routine practices done during and to laboring women are counterintuitive to how the body is designed to give birth. And that realization changed everything for me. The series is not about attacking hospitals. It's not about shaming women who choose hospital births, and it's absolutely not about discrediting OBGYNs, many of whom do critical life-saving work in emergencies. But for the majority of low-risk pregnancies, I think we need to slow down and take a closer look. So in this series, we're going to explore the physiological mechanisms behind birth so we can understand the real risks of hospital birth from a biological perspective. This isn't about fear. It isn't about ideology. It's about logic and truth. And it's about informed choice. My intention as someone with some medical training is to share knowledge so women can make decisions from a place of understanding rather than pressure. Whether you choose a hospital birth, a birth center, or a home birth, having information can only empower you. And that is my mission here, to help women reclaim autonomy through education. Birth is not just a physical act, it's a neurohormonal event. And the body does not open just because it's instructed to. It opens when it feels safe. In this episode, we're going to explore how the hospital environment itself can quietly act as an invisible brake on labor, long before drugs and interventions are ever introduced. This is part 1. Let's get started. Before we can understand the environment, we have to understand the hormones that actually drive labor. The most important of these is oxytocin. Oxytocin is often called the love hormone. But during birth, it is a primary engine. It coordinates uterine contractions, which are what physically push the baby out during birth. It also helps to soften and open the cervix, which is the opening the baby must pass through before being born. And oxytocin triggers the release of endorphins, which provide the body with natural pain relief. But oxytocin does something else that's rarely explained. When oxytocin and endorphins rise together, they induce an altered state of consciousness, often described as a labor trance. In this state, time feels distorted. Awareness turns inward. The thinking mind quiets. Instincts take over. This trance is a protective biological feature of physiological birth. It allows the mother to surrender. But for this flow to happen, a laboring woman needs to feel relaxed, private, unobserved, and unhurried. When those conditions are present, the body fully enters birth mode. But there's a second player in this story, epinephrine, also known as adrenaline. Adrenaline is the hormone of survival. It prepares the body to fight or flee. While it's essential in true danger, in the birth room, it is a direct antagonist to oxytocin. When adrenaline rises, oxytocin falls. This isn't just a feeling, It's mechanics. Adrenaline binds to receptors in the uterine muscle that tell the uterus to relax, signaling contractions to slow or stop. And remember, contractions are what push the baby out. At the same time, blood flow is redirected away from the uterus and toward essential organs like the heart and lungs. The body is being intelligent. It is responding to perceived threat by preparing for survival rather than birth. Closely linked to adrenaline is cortisol, the hormone of sustained stress. Together, adrenaline and cortisol keep the nervous system in a state of vigilance. They send one clear message to the body: this is not a time for rest. This is not a time for surrender. And this is the core issue. The body cannot be in survival mode and birth mode at the same time. So where do adrenaline and cortisol enter the story anyway? Let's talk about what happens when a laboring woman enters a hospital. To understand why the body presses the brake on labor, we have to look at the environment through the eyes of the nervous system. Hospitals are designed for emergency response, not physiological birth. Bright lights, monitors beeping, strangers entering and exiting, doctors and nurses treating you like your laboring body is pathological, conversations happening around your body instead of with you. To the nervous system, this constant state of alert can register as a threat. From an evolutionary standpoint, pressing the brake on labor makes perfect sense. If a laboring mammal is being hunted, it is a survival advantage for labor to pause so she can move to safety. In a modern hospital, the threats aren't predators, but the body doesn't know that. Lack of privacy, being watched, the ticking clock of institutional protocols. To the nervous system, these can still signal danger. Across mammalian biology, one pattern appears again and again. Labor progresses best when the birthing individual feels safe and undisturbed. When a laboring woman is continuously observed by unfamiliar staff or by the unblinking eye of a monitor, it can disrupt the shift into the altered instinctive state often called labor land. It's difficult to fully surrender into that state when the nervous system remains alert and analytical. This is because birth hormones are not produced in the analytical thinking brain. They are produced in the primitive brain, the part responsible for involuntary survival functions, breathing, heart rate, and reproduction. It works best when you are in an instinctive state. It thrives in darkness, warmth, and privacy. This is why many women in deep labor stop speaking, close their eyes, and move rhythmically. They have successfully shifted into their primitive brain. The thinking brain is known as the neocortex. It is responsible for logic, language, math, and social awareness. Ideally, its job is to shut down so the primitive brain can take over. The neocortex is highly sensitive to the environment. When you are asked to sign insurance forms, answer questions about your pain level, or listen to medical staff discussing your stats, the neocortex wakes up. Even in silence, the room continues to speak through technology. Electronic fetal monitoring often becomes a third presence in the room. Every beep, every line on the screen, every pause, each sound triggers a small spike of cortisol. So under these stressful conditions, adrenaline climbs, sending a signal to the body that it might not be safe to give birth yet. Because the primitive brain cannot distinguish between a doctor is asking me questions and a predator is nearby, it slows down the production of oxytocin to pause the labor until you can find safety. This is why contractions may slow or become erratic. Also, as mentioned before, adrenaline shunts blood away from the uterus and redirects it towards essential organs like the heart and lungs. As a result, placental perfusion decreases, and because the placenta is responsible for delivering blood and oxygen to the baby, reduced placental perfusion can show up as changes in the baby's heart rate, often interpreted as fetal distress. So when labor slows shortly after admission, this isn't a mystery. It's a predictable physiological response to stress, yet clinically it's often labeled failure to progress. The body isn't failing, and the woman isn't doing anything wrong. The body is responding intelligently to perceived unsafety. This stress is often compounded by the loss of autonomy. During my OBGYN rotation, I heard a physician joke that the length of a woman's birth plan was directly proportional to her likelihood of getting a C-section. That comment reflects a deeper problem. A woman's desire to participate in her birth is often treated as resistance rather than collaboration. This also highlights the nocebo effect. If the provider believes she will fail, their actions consciously or unconsciously often steer her towards that failure, to which she ends up with a C-section she never wanted and or was not expecting. Furthermore, hospital language like, "we're going to do an exam now," signals to the nervous system you are not in control. That perceived loss of agency activates the amygdala, the brain's alarm system, and at this point, the invisible brake is fully engaged. But the brake isn't just hormonal, it's structural. Movement in labor is a biomechanical necessity. It allows the pelvis to open and the baby to rotate, reducing the risk of malpositioning. Yet, many hospital births default to the lithotomy position, lying flat on the back. This position is anatomically obstructive. The weight of the uterus pins the tailbone shut. The pelvic outlet narrows. When a woman lies on her back, she is essentially trying to push a car out of a garage while the garage door is halfway closed. Furthermore, in the lithotomy position, major blood vessels like the inferior vena cava, the main vein returning blood to mom's heart, can be compressed, reducing circulation to the placenta, which, as we stated earlier, is responsible for delivering oxygen to baby. When that oxygen dips, the baby's heart rate changes. That electronic fetal monitor screams. The room panics. And suddenly, an intervention is used to save a baby from a crisis that the hospital's own positioning created. So let's pause and recap. Before a single drug is administered, we've already identified two major ways the baby's environment in utero can be affected. First, stress physiology redirects blood away from the uterus and placenta. Second, positioning can physically restrict circulation. Both occur before medication enters the picture. And as we move through this series, we'll see how drugs, commonly used to manage labor, can further alter blood flow and oxygenation, often compounding the very stress they're meant to resolve. When birth takes place without comfort, privacy, autonomy, free movement, or true consent, the body does not enter birth mode, it stays in survival mode. Pain is perceived more intensely. The labor trance is disrupted. The experience becomes harder for the nervous system to integrate, not because a woman failed, but because her body never felt safe enough to soften. When the body senses danger, it tries to slow down until safety is restored. But in the hospital, labor is rarely allowed to pause. And when the body doesn't comply with institutional timelines, the brake is overridden. That chemical override, that forced acceleration, is where the cascade of interventions begins. And that is what we'll explore in part 2.